Good evening and welcome everyone to my IVF Fences and our IVF webinar tonight. And welcome back to all of you that have been with us before. And as you can see, this is another topic and our special guest. If you've been here with us before, you know Dr. Halyna Strelko is right here with us, and you might be already familiar. So welcome back, Dr. Halyna. It's great to have you back. How have you been? It's great that you have joined us once again and will present another topic. And you have presented some of the topics on success stories, but this is another topic on genetic issues, embryo biopsy. So I'm glad that you will present something else tonight. And how are you feeling? How have you been?
Thank you, fine. This is a great pleasure to be here. This is my third webinar, and I think that today's topic is very, very interesting and quite provocative. I will explain why and hope it will be quite interesting.
I have no doubt because, as you've mentioned, this is always controversial, right? I would say that genetics, it's always a controversial topic. So I'm glad that we are talking about it. And I'm glad that there are patients here that are interested in this topic. And I'm sure that you have lots of questions on this particular topic. And well, I can only I'm sure that Dr. Halyna will tell you all about it, and will be happy to not only tell you a little bit on how it works, but also she will, as always, she will present some of the cases on this topic and then answer your questions. So remember, we will start with the presentation, but afterwards it will be time for your questions. So if you have any left, if you have any questions in regards to embryo biopsy, PGT-A, PGT-M, or PGT-SR, you will be able to ask Dr. Halyna, and I'm sure she'll be able to help you out. Remember, there is this time of Q&A session right after the presentation. And let me just mention that my IVF Fences is a part of European Fertility Society, and we are here almost at least twice or three times a week just to support you, just to give you the chance to ask your questions. And we will be here and we will be happy to help you out in any way that we can. And I know that some of you have been joining us over and over again, and that only means, I guess, that you are finding this interesting, you are finding this useful, and we are hoping to be here every time that you need something. So just remember, okay, this is all for you. This is free of charge, and we definitely only want to encourage you to ask your questions. So we will start, okay, on the topic tonight. I've seen the presentation. It's going to be interesting, I guess, as well. And afterwards, it will be time for your questions. So don't hesitate. It's your time as well. Okay. So go ahead, do it, type those questions in. And let me just mention that Dr. Halyna, she's the co-founder and leading reproduction specialist at IVMED, which is located in Kyiv in Ukraine. And she's been with us before. This is her third webinar, as she's mentioned. So if you haven't seen any of the webinars, remember that you are always able to rewatch all the webinars with her after we finish as well. Okay, that's it from me. Let's get going. I'm really looking forward to what you have prepared, Dr. Halyna. And well, yeah, let's go ahead, okay, with our presentation tonight.
Yeah, let's go. Thank you.
Thank you so much indeed.
So we will start. Yeah, as I have mentioned, the topic today topic is genetic issues, and why it is provocative? Because since last 10 years, it was thinking that genetic testing of embryos will resolve all problems of repeated implantation failures, of spontaneous abortions, of not successful IVF treatment. But finally, we understand that it is not so easy as it was thought before. And today I will present you the interesting clinical case, and then we'll try to explain why sometimes the standard genetic approaches may be not so helpful, and how we should change and modify these approaches, and probably it will be the gold standard in next 5-10 years. So let's start. The clinical case that we will see this evening concerning to my patients of advanced reproductive age. She come in our clinic when she has 42 years old, 11 years of infertility. She has one spontaneous pregnancy 12 years ago, delivery, healthy baby, but after that was unable to become pregnant. She has quite high ovarian reserve. IMH was 6.4. She was PCOS patient with normal weight. Her husband has no problem with sperm number, count, or morphology. And previously she has done one IVF attempt in another clinic. They receive a lot of eggs, 28 eggs, receive 8 blastocysts, has done NGS diagnostic, PGT-A, receive only one euploid embryo, cryo transfer, biochemical pregnancy. After that, she decided to change the clinic, and that's it. She come in our clinic 2 years later. We discussing with her that, okay, with her PCS ovary will be good to do standard antagonist protocol with triggering with agonists, which prevent ovarian hyperstimulation syndrome. But from the other hand, necessary to receive as minimum 20-30 eggs, because on low blastocyst formation rate and low euploidy of her blastocysts. So we has done the standard protocol with 225 FSH per day, and we receive quite big number of eggs, 50 eggs. She has no any hyperstimulation, was fine, no liquid, no pain. Fertilization was done with ICSI. We received 11 blastocysts from all of these eggs, and for euploid embryo was very good. And we start to do the preparation for cryo transfer. So first protocol was standard replacement hormonal therapy, 6 milligram of estrogens and micronized progesterone, 600 milligrams by vaginal way. Test unfortunately was negative. Okay, we decide to do second protocol with natural cycle with triggering with HCG, because on some time a natural cycle can give more natural level of hormones, better progesterone level, better functioning of corpus luteum. So we modify our protocol, follow her growing follicle, then HCG triggering, ovulation, and from the day of ovulation we start the support of luteal phase with 400 milligrams of progesterone. Test was also negative, unfortunately. Natural cycle protocol was the third, absolutely natural, without HCG. The same progesterone 400 milligrams by vaginal way, and unfortunately one more test was negative. So we has no anymore the normal euploid blastocysts, and we decide to do the second stimulation. So in this moment we receive the new gonadotrophin, folitropin delta. The main interest of this medication was that we can calculate the dosage individually according IMH level and body mass index, and in some cases it gives better result, little bit less eggs, mostly never hyperstimulation syndrome, better quality of oocytes, better blastulation. So we decide to change medication, hoping that it will give better embryological issue. With folitropin delta with quite low dose, we receive less eggs, 34 oocytes, also fertilized with ICSI and received 5 blastocysts. 3 of them was absolutely not good, type C. Type C normally we don't freeze because they never give pregnancy. Type C mean low number of cells. And only 2 more or less good quality blastocysts. NGS test showed that no euploid blastocysts. Total disaster. So patients decide to do the third stimulation. So we discussing with her that, okay, she has good ovarian reserve, so we can expect to receive quite a lot number of eggs. But as she has high level of aneuploidy, probably necessary to modify the embryological approach, and probably Trophectoderm biopsy, which we are doing for NGS testing, may be a factor decreasing implantation potential of embryo. After we will see that in some scientific publications, they after say that Trophectoderm biopsy may be sometimes harmful. And also we decide to do the transfer of her embryos in totally natural cycle because also it may be better endometrium quality, receptivity, and also wider implantation window. So we are moving to the third protocol, the same dosage, because first time we received a good number of eggs. Trigger with agonists, we receive 49 oocytes, and decide also to do piezo activation after ICSI procedure. In previous webinars, we discussing that it may be sometime the method which can improve the cleavage and blastulation rate, because this increase the concentration of calcium inside of oocyte, and we know that calcium may improve and need for good cleavage and good fertilization. So we receive 9 blastocysts and decide to do non-invasive PGT-A to avoid the influence of Trophectoderm biopsy. Unfortunately, we received only 1 euploid blastocyst. It was really a little bit not expected, but anyway, we decided to preparing our patient to cryotransfer in natural cycle, and finally we receive after all these attempts the positive test, and you can see the photo. She has not only the test but pregnancy. 2 weeks ago it was 6 weeks of pregnancy. So what I would like to talk in after this case. From one hand, we are know that maternal age unfortunately influence the human embryo aneuploidy. It means that after 35, 36 years old, the percentage of aneuploid embryos increased dramatically, and after 43, 44 years old, most of embryo are abnormal. And that's why mostly all clinics and mostly all doctors propose to patients doing NGS testing, PGT-A, for embryos, because it may improve the selection and should improve, and really in some publication it is written that it is improved the pregnancy rate when we are calculating per transfer. We can see in this slide that there is 3 main sources of aneuploidy of embryos, and paternal part does not change a lot. The problem which occurred during the cultivation also more or less stable, and represent around 20-30% of all aneuploidy. And probably we can influence this part by changing the embryological protocols, but the quality of eggs and how to say maternal meiotic problem increasing dramatically with woman age. From the other hand, last 5 years appear a lot of publications concerning the technique of Trophectoderm biopsy, methods, influence of laser hatching, and I would like to present you a couple of these works. So, for example, we can see that Trophectoderm biopsy protocol can affect clinical outcomes because, there are two main techniques which we can take these cells from embryo. Technique when we first open, I will return the slide, when we open little hole in embryo day 3, and then through this whole part of Trophectoderm come out, and then it is more easy, of course, to take this part from the embryo. And another method when we don't open like that and taking biopsy when embryo reach the specific stage. But when we compare these two methods, there are pro and contra, and it is very difficult technical issues. And for example, most of patients and most of doctors does not discuss in this question with embryologists. Embryologists decide, okay, I will do like that, but in most of cases nobody know how it was done. And according the method how it was done, it may increase some percentage of aneuploidy, of mosaicism, and may influence on blastocyst viability also. For example, method of opening may give sometime bigger part of embryo passing through this hole, and also this part may be, how to say, and the embryo may divide after that and give some kind of damages. With this method, sometime embryo may collapse it, and after not opening well. Also, if we compare mosaicism rate with different method of biopsy, we can see that it may be more or less twice difference in mosaicism. And we know that sometimes we refuse to do the transfer embryo with mosaicism because we're afraid to have genetic problem, genetic disorder. But we can see that sometimes the result which we can receive from genetic laboratory may be, how to say, influenced by technical problems, technical questions. Yeah. Also, we can sometime pulling these cells from embryo, sometime can flicking, and also it may change and may influence the viability of embryo. For example, you can see in this table that, for example, method of pulling, we have 48% of transferable embryo, with flicking 55%. Mosaicism rate in one case it is 17%, and another case 9%. So, okay, it is quite big differences for me, and especially if patient has only one embryo or two embryo. Okay, it may totally change the situation, and in some case we can refuse to do the transfer, or patient can refuse having this information because thinking that embryo is not good, for example. When we are talking about trophectoderm biopsy, should be discussed some critical questions: the timing of zonar breaching, whole of this when embryologists doing the hatching, smaller, larger, how many cells to take in, 10, 5, 4, pipette size, timing of trophectoderm sampling, biopsy method, using laser, time of laser shot, also condition of the washing after biopsy, freezing, tubing process. So a lot of questions which can be important for the final result and which are not discussed really during the consultation, and even most of patients and doctors does not take attention to all these things. Also interesting publication concerning cellular integrity after biopsy. Yeah, for example, embryologists can take cells and all cells are not damaged. Grade 1, grade 2, little damage. 90% are okay. Grade 3, around more than 50% are okay. And grade 4, most of cells are damaged. And in this case, we can see that mosaicism rate and euploidy rate may be different between grade 1 and grade 4. Yeah, you can see 2-time difference. It is mean that in this case, 2-time more embryos considered are as abnormal, and we will not transfer them. And the same for mosaicism rate. So more damaged cells we have, more embryo considered as mosaic. Also, when we reanalyzed blastocyst after trophectoderm biopsy and can see the total cell mass, we can see that around 68% of all embryo give the same result, but it means that 30% of embryo can be different. So, okay, it is the method which can give around 30% of not exact result. Also, another publication concerning trophectoderm biopsy protocol, which can impact the mosaicism of blastocyst. So we can see the same, that some methods give more mosaicism, some methods give less mosaicism. Also, one important thing that sometime when we opening our embryo in day 3, we can have trophectoderm cells in this hole, but sometimes we can have part of cells of future embryo, inner cell mass. And in this case, also, if we take these cells, it may damage the viability of our embryo. One more possible problem, that for the opening of zona pellucida, in most of cases, embryologists using high temperature laser. Yeah, and okay, this high temperature may theoretically influence the viability of cells and cells integrity. In most of publications, it is written that, okay, it is not very big and important influence, but also it depends on qualification of embryologist, of quality of blastocyst, number of cells, how they are present, etc. Also, concerning mosaicism, we should know, and also euploidy of blastocysts, that in most of cases embryos are mosaic. And when we are taking the sample of embryo, We can take sample from this part of embryo and receive like 40% of mosaicism. We can take from this part and receive healthy embryo, from this part, yeah, and receive absolutely aneuploid embryo. It means that we cannot analyze all cells of embryo. We can take sample, and this sample may not be always representative in terms on euploidy or aneuploidy of total embryo. So that's why the science moving forward. And last year, the appeared interesting method of testing called non-invasive approach. It means that this liquid surrounding blastocysts, which contain DNA, may be analyzed, and this liquid may represent not only cells surrounding inner cell mass, but also some cells from inner cell mass. And it was shown that if embryo was considered as euploid, the probability of pregnancy is very good. If considered as aneuploid, normally no viable pregnancy. There are a lot of embryo which were analyzed by this method. We have quite a lot of publications now. And concordance rate of free cell DNA, it means DNA containing in this liquid, and Trophectoderm biopsy is quite high, around 80-90%. Okay, it is probably not 100% correspondence, but 80%, as for me, it is very good number. And this method not need the invasive procedure in embryo. So in some cases may be really helpful and give quite good information, quite reliable information about embryo. So as a conclusion, I think we can say that PGT it is important tool in IVF practice. It is like gold standard now. But patients with advanced reproductive age may, from the one hand, has benefit from genetic testing, but from the other hand, trophectoderm biopsy can impact the viability of embryos. So, as we can see, the concordance rate of classical and non-invasive PGT-A is high. We can thinking and recommending non-invasive PGT-A as beneficial for patients with low number of blastocysts and with average quality of their embryos. Thank you for your kind attention, and I will be happy to answer all your questions. I see that we have yet a question.
Excellent. Thank you, Dr. Galina. As always, it's been very interesting. Thank you so much for providing the story, the success story, but also explaining how PGT-A works, when it's beneficial, and when it should be recommended. Of course, this is, as you mentioned, controversial sometimes. So thank you so much for explaining when and why. And as you can see, there are some of the questions ready. Some of those I do see they are quite detailed right here. So thank you so much, everyone, for joining us tonight already, and of course for your questions. And let's get going with our Q&A session, okay, Dr. Galina? Ready?
Yeah, with pleasure, with pleasure.
Glad to hear that, then, of course. Okay, let's have a look. Okay, there's a question for one patient, two parts of this. So let me just have a look at both of those. Excellent. So can I ask what pregnancy chance have with 2 grade 1 embryo frozen on day 3 and 41, but I froze the embryos when I was 40. They were not genetically tested. Also, do you recommend prolonged use of DHEA and CoQ10 for repeated IVF procedures? Does it cause any harm if taken too much? Thank you so much.
Thank you. Good question. There are a lot of little questions inside, so I will try to answer one by one. Pregnancy chance I have with 2 grade, one embryo frozen on day 3. Okay, first problem that day 3 embryos, we don't know if they will reach blastocyst stage. Okay, one egg and one embryo give around 4 till 6% chance to have live birth. So this is probably the average chance with one embryo. Of course, better to see and better to do the prognosis with blastocyst stage embryos. If it is the same embryo and we transfer day 3 or blastocyst stage, mostly the probability of pregnancy is the same. Only with blastocysts we are more sure that embryo are viable and has more or less good chances to be implanted. At 40 years old, the average percentage of genetically abnormal embryos are 70-80%. But in your case, nobody knows without diagnostic. Probably this embryo is good, probably no. We have no possibility to answer. In young age, the morphology is correlated better with genetic of embryo, and with advanced reproductive age, this correlation is less pronounced. So we cannot say only with morphological description of embryo is this embryo has chance or not. We can, of course, do genetic test of this embryo, cultivating till blastocyst stage, doing biopsy, then freezing. Is it really necessary to do? This is a big question because, okay, as we have seen, there are some false positive, false negative results with PGT-A. If there is no choice of embryo, as for me, better to transfer and not to do these tests with the embryo. Concerning the prolonged use of DHEA and coenzyme Q10, no, there is no problem. You can take during a year, 2 years. No publication which saying that it may be the problem, may be harmful, so it may be helpful. You can continue. So like that.
Of course, understood. Thank you so much, Christina, for your very first question and your help with that. I do believe it has been helpful so far. Actually, Christina has another question. Okay, so let me go to the next question here. Also, I'd like to ask which progesterone supply would you recommend between Dufaston and Lutetium? I heard that Dufaston could increase breast cancer risk if taken for longer periods of time. Is Lutetium the same, and why? Anything you can advise?
Thank you for your question. Louis guessed it is probably commercial name. I'm not sure that I know the exact what is contained. I will see. Because in each country the commercial name may be different, and probably it is something like Utrogestan, but I don't found. Will be very helpful if you will write Louis guest the chemical name. What is it? Concerning Dufaston, I don't see a lot of articles about Dufaston saying that it will provoke breast cancer. From the other hand, if we don't take progesterone, taking replacement hormonal therapy and only estrogens without progesterone in the second phase, it may provoke the risk of endometrial cancer. So as for me, if you can change oral progesterones and oral estrogens if you take in for replacement hormonal therapy to transdermal form, because oral form provoke the cholesterol increasement, and better to take by transdermal or transvaginal way. Probably Louis just it is something like Trogestan, and we can use by transvaginal way. But okay, Nestor, that I see, I don't. In Ukraine, there is another commercial name. We have no such commercial name.
Understood, of course, perfectly. Thank you so much. Christina, if there's anything else you would like to add, of course, you know what to do. Go ahead, type this in. But I guess, Dr. Halyna, this has been helpful from Christina. There's this answer. Thank
I try to find in internet Louis guest, but
Okay,
I don't found, unfortunately.
I
I don't.
understand.
Yeah.
Well, remember, Christina, that if you have any more questions or if you would like to get in touch with Dr. Galina, there is a possibility. I would be happy to forward your question to Dr. Galina, her team at IVMED, and I'm sure that if they have more questions, if they have more details, they will be able to answer this for thoroughly as well, right? So I guess that will be possible as well. Thanks so much. But as you can see, thank you very much for your answer here. Okay, I guess we can have a look at next question from Claire. Okay, so it's a bit of a longer question as well. And I am 41, have had 4 failed IVF cycles. I am due to have hysteroscopy. If no concerns found, I have been advised to have embryo testing. I have 3 embryos frozen, but it has been suggested to leave those and have another egg collection and test those embryos if I get any. Would you agree with another egg collection and leave the frozen embryos due to the risk of re-thawing before transfer?
Very good question. Thank you very much. It is really sometime a big question if necessary to thawing embryo, take biopsy, and then freezing them. Of course, each extra manipulation with embryo may provoke the damage, and of course, it depends on quality of embryos before freezing. If we have Trophectoderm not with a lot of cells, quality is not very high, more manipulation we are doing, less viable this embryo will be after that. From the other hand, we have couple of publications saying that okay, we can freeze so and all will be okay, but from the another we have publications saying that several cycles of freezing and sowing can decrease viability of embryos. With frozen embryos we cannot do in non-invasive PGT, so for this purpose for sure we should do the new embryos. And the new stimulation also may be helpful because, as I have mentioned, at 41 years old, we will have, in average, 80% of embryos with genetic abnormalities. So more embryos we will have, more probability that we will have as minimum 1 or 2 with normal genetic. And if, as you have seen in my presentation, from 50 eggs at 43 years old, unfortunately, we has like 1, 2, 3 euploid embryos. And for this purpose, as for me, better to do the next, the new stimulation and testing embryos, but discussing by which method. If possible, non-invasive, probably, or discussing which kind of technique will be used for trophectoderm biopsy, so like that.
Again, thank you so much, Claire, for your question. And Dr. Kalina, thank you so much for your help with that. And as you can see, Claire has added thank you for your answer to this. And let's have a look, okay? Another question, another detailed question for sure.
Yeah, very
Lucy.
detailed.
So let's have a look. I am female, nearly 36, never been pregnant before. I have a balanced translocation with chromosomes 7 and 8. My husband's karyotype is normal. He's 36. We had 2 rounds of IVF this year, 34 oocytes, 12 embryos, none came back normal. Is that normal? Bad luck. I don't want to consider egg donation. Any suggestion to succeed on a third ovarian stimulation? What is the percentage of success if our case, balanced translocation plus 36 of age? Thanks, Emil, and much appreciated. Thank you so much.
Yeah, thank you. Thank you. Interesting question and interesting situation. And really difficult to do the prognosis. With balanced translocation, normally it is thinking that we should have more or less 20-25% of balanced embryos. But from the other hand, we have some percentage of aneuploidy with or without translocation. And also it is very individual. Recently, I had a case with a woman with also balanced translocation. She has born 2 normal healthy children without IVF treatment. She has 39 years old, and she come to our clinic with her sister who has 45 years old, and she was like egg donor for her sister. And okay, we don't expect to have even one normal embryo. She has not very high ovarian reserve, and we received 2 balanced embryo with normal genetics. So it is really by luck, by chance. And also the embryological method of working with your eggs, with your embryos, may influence the percentage of genetic abnormalities, because it was very interesting publication about egg donation cycles. In some clinics, even after egg donation, the percentage of genetically abnormal embryo reached like 60, 70, 80%, and in some clinics it was like 30%. So egg donors normally young women without genetic problem, and it may be so different, depends on methods of working, purity of air, medium which were used, etc., etc. So some practical, some technical things in embryological laboratory. So as for me, you should try probably in another clinic, and probably discussing which method of work they are using normally, and try to see what will be with your embryos and which will be the percentage of normal or abnormal embryos.
Again, thank you so much, Lucy, for sharing, but also for your help with this and your advice. And of course, let's have a look. Lucy has added one more question. So, what is the minimal recommended time to take CoQ10, by the way?
Thank you for your question. It is thinking that as minimum 60 days before you start your stimulation, as minimum. But you can take it more prolonged time, like 3, 4, 5 months, even more. But minimum it is thinking 2 months.
So
60
there's
days.
no harm even if someone is taking it for a few months already.
Yeah, some people take it for,
Okay.
how to say, general health, because it is antioxidant and
Right.
may increase your energy. So you can take
No
it.
harm in using this,
Yeah,
even
no
taking
harm.
this.
Yeah,
Okay,
exactly.
perfect. Thank you so much for the clarification in such case. Okay, and one more from Lucy. What is the progesterone used recommended for?
For what? Good question, but I don't really understand the question. So, if you are meaning progesterone for luteal phase support in, for example, cryo protocol or in fresh cycle, normally we are using micronized progesterone like utrogestan or like something like that, close to natural. Sometimes we can use progesterone in injections, but it is quite difficult for patients to do injections mostly every day. So, uh-huh.
Lucy has added that actually this is a question in regards to this one. Yeah, it's in regard to this
Okay,
question.
okay. So, yeah, in this case, probably better to use micronized progesterone, and probably vaginal way is the most, how to say, less harmful. So we can use this kind of progesterones, but also depends on the purpose for which you are thinking to use the progesterone. If it is for luteal phase support, it should be bigger dosage and better always to measuring your progesterone level in blood, because even some dosage, even some way of taking of progesterone and some body mass, same body mass index may give absolutely different levels in your blood circulation. And even in literature, we have the term like progesterone resistance. And we are doing that systemically, and around 20-30% of our patients with good dosage taken correctly has quite low level of progesterone in blood. So this is for cryo protocol or fresh cycle luteal phase supporting. If it is for endometrium problem prevention, we can use much less progesterone dosage, low progesterone dosage, like 100, 200 of milligram of micronized progesterone during 10 days, second phase of cycle. So depending what is your purposes to use progesterone.
Well, again, thank you so much indeed, Lucy, for your follow-up. And let's have a look, okay? There is another question. So do you offer non-invasive embryo testing? And if not, do you know which IVF centers offer it?
Yes, thank you for your question. We are start to offering non-invasive embryo testing, and this morning just we are talking with laboratory who are doing for us this testing. iGenomics, and yeah, of course, there are a lot of clinics in Spain, like IVI clinic, and also another clinic who are working with this laboratory, like outsource. I cannot mention you all this clinic. I don't know, but our clinic, yes, collaborating with iGenomic laboratory, and we proposing this non-invasive test to our patients.
Sounds definitely interesting. I guess so. This is something, of course, new, but you are already starting the process with this non-invasive embryo testing. Then, yes, I understand.
Yeah, yeah.
Okay, that sounds great. I mean, iGenomics might not be familiar, but of course we've been having some webinars with iGenomics already. So this is definitely a promising method. We did a webinar on non-invasive PGT, so this is something that you can of course check it out on our website as well if you are interested. So I hope that this is yeah, it's always amazing to see some new developments, I guess, as well. Thanks so much indeed for mentioning this. Okay, let's have a look. There is another question coming up, so might be our final question. So if you have any more, you know what to do. Go ahead, type those in. And Lucy has added, would you recommend DNA fragmentation or more sperm testing too? In regards to the previous question, of course, I can show you that as well.
Yeah, thank you. Thank you for your question.
This
Uh,
is from our previous patient, right? So this is
uh,
the more or less
okay,
the
great.
story.
Yeah, normally we are doing some advanced genetic testing for our patients, especially with low blastocyst formation rate. And we are doing oxidative stress. We are doing also DNA fragmentation test, and sometimes fish test. We are measuring the percentage of aneuploid sperm cell. And in case on we are found that DNA fragmentation is very high, we can propose some specific methods of sperm preparation, which help us to select the sperm cells without or less DNA fragmentation. For example, we are using what we call sperm chip, a specific method of selection, and it decreased the percentage of DNA fragmentation around 30-40%, and we have better blastocyst formation rate after and less aneuploidy rate also. So yeah, we're using these techniques.
Understood, of course. Thanks so much. More questions are coming in also from Lucy, and this is definitely interesting here. So, one of our embryo has been diagnosed as high risk mosaic. What are the risks of transferring this percentage of success? Anything you can advise?
Uh, yeah, good question. Thank you. And it is also the topic of big discussion in literature and a lot of controversial publications. High risk mosaic, it is mosaic rate more than 50%. But as you have seen during the presentation, also it may be sometime by chance embryologists cannot see which part of embryo was taken, and sometimes these cells, abnormal cells, may be like clusters. And if we are doing the second biopsy, we can consider this embryo as low level of mosaicism or abnormal or normal. So the correspondence, if we do the second biopsy, may be like 20-30% less or more. So okay, we can transfer mosaic embryos. Some problems like Down syndrome or trisomy of 18 chromosome may give after some health problem to children if this embryo will implant. So recommendation that some types of mosaicism not very recommended to transfer. Some of them is more or less safe to transfer. The main problem that mosaicism may increase the spontaneous abortion rate. And if pregnancy occur after the transfer, will be good to do some additional genetic tests to this pregnancy, like NIP test or like amniocentesis will be even more information with this technique. So like that.
Lucy, thank you so much for your question, indeed. And there is a follow up, okay, Dr. Galina. So let me go
Yeah.
straight to that. It was 46 chromosomes, I guess. You can see the details. I'm not really sure here.
Uh-huh. Yeah, I see. But how to say? What is the question? This is the
Lucy?
description of some of something, but
Of course. Let's wait. Someone
what
is
is the
typing, okay?
question?
Okay. This was the description of the high
Why
mosaic
mosaic?
embryo.
Okay, I understand.
Yep.
Okay, I think you can transfer this embryo It is not 21st chromosome, not 18th chromosome, but if pregnancy will occur and will be viable, and after 16 weeks, you can discuss with your doctor probably the procedure of amniocentesis, and it is quite safe. And you can receive the whole 24 chromosome information and see some additional tests, even some molecular genetic tests, so some mutations. So you can do all possible examinations with these genetic materials, and it is quite safe and a lot of information which you can receive. So I think you can transfer your embryo.
Thank you so much indeed. Lucy, if there's anything, of course, go ahead. Thank you so much. There's an answer. Thank you very much for all your advice. Well, couldn't agree more. Thank you so much indeed. And I believe that might be our final question, very straightforward question. In non-invasive, PGT, just is it possible in blastocysts, or how does it work?
Yeah, exactly. This is only possible in blastocyst, and better to do 6-day blastocyst. It is more exact with more advanced blastocysts, so not 5-day but 6-day blastocyst stage. And it is impossible to do with frozen embryos. We cannot thaw in blastocyst stage and give the result of this test. Necessary to cultivating the blastocyst, and all this liquid should be used for the test, not with previously frozen embryos without test.
Okay, definitely. Thank you so much. Well, this is definitely interesting because I think that in recent times it has been something that it's been talked about, but not many clinics were like, okay, we will start doing this. So it's definitely interesting that it's something that might actually, the clinics might be offering this, I guess, more and more. It looks like it. Am I right?
Yeah, it's true. Clinics searching the new possibility for their patients, and it seems that non-invasive PGT-A may be helpful for some category of patients. Okay, we will see that with more statistics, more
Of course.
cases, but it seems it is interesting and quite promising.
And it's worth to check for sure. Worth to look out for as well, I
Yeah.
guess, right? Okay, sorry. Sebastian has asked one more question. So you have to freeze afterwards, right?
First, necessary to cultivate, take this liquid material for diagnostic, and then freeze, and not opposite. First freeze, then thaw and take, and that's so on. So first necessary to take liquid after cultivation, during cultivation, because DNA pass from embryo to this liquid, and only and should be some exposition, how to say, yeah, necessary to have some concentration of DNA inside.
All right. Thank you so much for additional question and of course for answering that. I believe it has been helpful. It might have been our final question, but of course, remember, if you have any more, you know what to do. You can get in touch with Dr. Galina, her team at IVMED, and I'm sure they will be happy to help you out with some more details. Definitely more details, because as I always mention, this is definitely a good opportunity for you to ask questions. However, if you need more details, doctors like Dr. Galina, they definitely need more details to answer you properly, to give you more details, to give you some more advice for sure. So get in touch with them, and I'm sure they will be happy to help you out. So thank you so much, everyone, for joining us tonight, for your amazing questions. Very thorough, very detailed, very interesting, not easy questions. This is
Yeah,
all
not
what we
easy, not
want.
easy at all.
And I'm glad it happens, because this is definitely important for everyone to ask how it works right now, how it changes, because it's amazing for me always to see that science is there, and of course it's developing and it's changing, and of course new opportunities show up every now and then, and it's great to see that they are actually recommended also at some clinics, and it's always great to see those new methods used, right? So thank you so much indeed. Remember, you can always get in touch with Dr. Galina, and also if you have any questions, you can get in touch with us. And let me just mention that this has been recorded, so you will be able to you will have a chance to rewatch this again. Dr. Galina, thank you so much for joining us tonight, for providing this interesting presentation, and of course answering all the questions. Before we finish, is there anything else you would like to add?
Thank you so much for your time, for your interest to this very interesting and controversial topic. And if you have any question, don't hesitate to ask him, to write him. I will be happy to answer. And have a good evening, have a good night, have a good week, and hope we will see next time in a couple of weeks.
Exactly. I'm looking forward to our another webinar, definitely. I'm glad that you have been able to join us, our team, and you've been able to provide those 3 webinars before, and I'm already looking forward to some more, that's for sure. Dr. Galina, thank you so much indeed. You've been an excellent expert here, and well, thank you so much for joining us tonight, everyone, because I know some of those topics are not easy ones, and sometimes I think that asking questions, you think that it's so easy, but I guess it's not always the case. So yeah, as Lucy has just written here, best of luck to all, and I cannot say anything else because we are all here keeping fingers crossed that everything will work out the best way possible for all of you. And I'm always open to hear some very positive thoughts and positive outcomes, for sure. This is actually the best time. Whenever I receive an email saying that something positive has happened and there's a positive test, it's always amazing to receive, anytime. So thank you so much. Fingers crossed. The best of luck to all of you. We will be back. There is another webinar tomorrow at 7 p.m. UK time. So I hope you will be able to join us. Another topic, another expert. And of course, I'm sure you have some more questions to ask. So just register, okay? And we'll be here. And thank you so much. Take care, everyone. And see you tomorrow, I hope, as well. Dr. Galina, till our next event, okay? Thanks so much.
Bye-bye. Thank you.
Take care. Bye.